Welcome back to Dental XP. And we recently had an opportunity to go to an implant summit and hear a gentleman talk on digital dentistry. It wasn't really digital dentistry as you traditionally hear it, but it was very much practice-centered. He'd somehow gotten all the different aspects together and was using them incredibly effectively in his practice. Dave, we look forward to you showing us how you've made this an integral part of your practice, how the workflow really does flow, using that terminology, and how even though you have different components from different companies, you found a way for them all to work cohesively together to simplify our lives and improve that of our patients.
Well, hello everybody. It's a pleasure for me to get the opportunity to present before you today on Dental XP. The title of the topic is Computer Enhanced Implant Dentistry by me, David Gachet. I would like to thank Dentistry Implants as well as David Garber, Eddie Salama, and Tyler for assisting me in getting configured and for the invitation. Before we start, I'd like to mention I'm receiving an honorarium from Dentistry Implants through Dental XP. Actually, Dental XP is sponsoring this through their relationship with Dentistry Implants. I've received in the past honorarium from Dentistry Implants as well as Materialized Dental and Ben Air 3Shade. Today we live in a digital world. Everything around us has changed, and we are adapting as best as possible to it. Some resist change and are laggards, others adapt easily to change and find that it suits them. We're all a little bit digitally challenged as the workflows around us are continuously being modified, they're new. If we think about behaviors we've used in our world from transitioning from the analog to the digital, we could think of analogies such as the digital cameras. Today, there's no question that we no longer use film for photography, we use digital processes. So who would guess that these behaviors of understanding the way a digital camera might function and the way that we share images through the internet digitally, that this would serve as a good basis for adapting to our changing world in digital dentistry. One way we could prepare ourselves for these changes is to acknowledge that there's cultural shifts occurring that need to change the way we think about adapting to dentistry, digital dentistry rather, change the way we think about workflows, adapting to different ways of doing things. We have to acknowledge that we may be somewhat digitally challenged, but we could be preparing ourselves for this. And some of the ways we could prepare ourselves for it is simply by acknowledging that there's a cultural difference. Sometimes it's just the way we think about how we go about our daily process. One thing we have to acknowledge that when facing change, it's uncomfortable. Eric Shinseki of the U.S. Army Chief of Staff said, if you don't like change, you're going to like obsolescence even less. So we have to acknowledge things are changing. If we're laggards, we may not be able to take advantage of the efficiencies the new workflows could provide us. But if we're very early on the curve, early adopters, or what we might call the bleeding edge in adopting technology, we might make the mistake of going into something too soon when it's inefficient, ineffective, and we could make costly mistakes. Those mistakes could be time lost, or it could be financial loss if you don't pick the correct software, hardware platforms for which we can get an efficient benefit. So we have to look at this as an evolutionary process. The next video I'm going to show you presents the machines and technology in a Darwinian evolutionary context. This next video is 40 seconds and it's called The Evolution of Machines. I hope you enjoy it.
CT-Auslese war hart. Doch jetzt ist sie da. Die Stärke.
Now what you've just seen is an artist's rendering of the evolution of machines depicted as we might see fish coming to the land animals turning into dinosaurs, into the Ice Age with the T-Rex and the saber-toothed tiger, onto the quadruped, biped. Finally, at the top of the machine food chain is the Fembot. And ironically, that's an ad out of Germany saying get the best electronics at Saturn, which is a electronics outlet. So in the context of assisted implant dentistry, computer-assisted implant dentistry, we're talking about making investments, making sure those investments work for us and make us more efficient, not obsolete or extinct. Now, we utilize computers in implant dentistry in a variety of ways. Digitally, we use them for diagnosis. A cone beam CT is an excellent import area to start the digital workflow. We also, in some instances, go beyond utilizing CBCT and use implant treatment planning software such as Implant. We also utilize this software from the cone beam CT surgically, because sometimes we order surgical guides and even make a stereolithographic bone model. Additionally, restoratively, we have the opportunity to make casts, custom Atlantis CAD-CAM abutments, and even the new Atlantis core file or immediate smile restoration and bridge. In the laboratory, we have laboratory scanning, and from those scans we can generate new generation of custom CAD-CAM zirconia restorations, which I'd like to elaborate a little bit more as we go on. So what I'm talking about is really realizing and creating a digitally based practice philosophy. It's not digital for the sake of digital, it's digital to take advantage of the strength that this new technology provides us to be most efficient. So one of the entry points into the digital workflow is the cone beam. Now the cone beam comes with native CBCT software, such as that which came with this Carestream 9300 image that you see in front of you. Some of those free softwares enable us to place implants, and they'll have a small implant library or even an elaborate implant library, and we can position implants and view those in several different cross-sectional views, and axial as well as coronal. Now in this cross-sectional view, you'll look at the breadth and width of the alveolus, and you can see that the implant that's being planned looks like it fits perfectly within the context of that bone. However, if you take additional slices, you'll see that there's an outcropping of the incisive foramen, which actually puts a very significant space limitation on the placement of the implant when juxtaposed to the lateral incisor. When viewed coronally, you can see, or in the axial view, you can see there's also the buccal plate. So between the lateral incisor, the buccal plate, and the outcropping of the incisive foramen, one might acknowledge that this would be relatively challenging to position the implant. So in this instance, even if there is enough bone, does the software alone give you the ability to actually execute on that proposed plan or that conceived plan? Probably not. So in that instance, we might want to pull that data into a third-party software such as Implant, which you see here. You can see overlaid a stone cast that's been scanned in and merged with the radiographic data. You can manipulate that data, look at cross-sectional views, and you can position implant, a prosthetic tooth. You can even view it at a variety of angles, and from that, order the surgical guide that you can see depicted in this image here. So one must ask, what are the real indications for ordering a surgical guide? Well, certainly one of those is to manage the critical space limitations, such as that one that I just illustrated. In this instance, we ordered a pilot guide and were able to execute the placement of the implant. So that brings us around to the question of should we use tried and true, the conventional surgical guides, or should we use the new generation of surgical guides, the computerized guides? Well, on one hand, we both have the choice of the conventional versus the computerized guide. The conventional guides have historically been restoratively driven. They're cast or measurement based, and they have really good information about hard tissue like the teeth and soft tissue like the gingiva and alveolar tissues, but they lack information about bone. The computerized guides have accurate cross-section imaging of bone at additional expense of exposure, radiographic exposure to the patient, time spent utilizing the software, and cost to the patient. And they tend to generally lack information about soft tissue. Now, the use depends on the condition of the patient, the needs of the patient, and the choice of the dentist. And in addition, we have to look toward the future as what is the best possible way to evaluate patients. If you can determine that there's a critical space limitation or a need or an indication to get a cone beam CT, we might acknowledge that there might be a benefit to merging data sets. So I'm suggesting there's a need to merge data sets. And what does that mean? Well, if we could digitize the stone cast you see on your left and merge it together with the radiographic data you see on your right, it might look something like this, where we have the cusp tips of all those teeth merged together with the optical digitized scan of the patient. And once those are merged together, that gives us the opportunity to evaluate the patient with all the data necessary to determine what would be in the clinical situation. Not just bone, not just teeth, but teeth, bone, and tissue. So to accomplish this, we need merged data sets. To achieve merged data sets, we need methods to bring in the data and software to compile the data. You can see we have the image of a cone beam CT, but to create a merged data set, we might also require a 3-shape lab scanner or a 3-shape intraoral scan. Now, in this compiled data, you can see optical scan of the patient's maxillary arch merged together with a radiographic scan and implant. Now, in this instance, that's not actually an optical scan, it's a radiographic scan of the cast of the patient merged together with the radiographic scan of the patient. But today, we might accomplish that in a variety of different ways, using intraoral scanner, laboratory scanner of the cast, and a variety of different approaches that may be more accurate than radiographic scans of the cast. My contention is that implant treatment planning software enables superior results. That's the basic theme of the next few minutes. I'd like to illustrate what I say that. But when we utilize cone beam CT and implant treatment planning software, we can either utilize it diagnostically to achieve a 3D scan, a plan, and order a conventional guide, or we can use it surgically, getting the scan, the plan, as well as a computerized guide. Additionally, you can utilize it restoratively, and that means getting the scan, generating the plan, ordering the guide, and with the guide, performing some procedures in the laboratory, maybe with the inclusion of a computer-generated immediate smile cast or an immediate smile bridge, immediate smile restoration. This implies the possibility for immediate loading. What are the indications for ordering a surgical guide? I think it's really to manage space limitations, either interproximal, vertical, buccolingual, inner implant spacing when you have multiple implants. And Schneider has done a review in the dental literature of all sorts of different articles on ordering guides and guide accuracy. Now, this first instance I'd like to show you is a patient who's 31 years old. She's a female salesperson who has come to the conclusion that after wearing these orthodontic brackets and arch wires. She's interested in getting out of ortho and having a Maryland bridge. She has difficulty speaking and accomplishing her work with the orthodontics in place. And her restorative dentist and her orthodontist had intended to move the cuspids into the lateral position, not realizing that those cuspids were dilacerated. They were very difficult to anchor the move, and they're achieving limited or compromised results, and they certainly do not have an ideal space to create room for a dental implant. So after a period of time, the patient comes to the conclusion that it might be in her best interest to stay in ortho long enough to create enough size for the space for a pontic. At that point, she concedes that we maybe should proceed with conventional restorative treatment with an acid etch Maryland bridge or a cantilever pontic from one of her natural teeth. I suggested she get a cone beam CT, and from the cone beam we could see that it might be possible to place some narrow diameter implants. When we take a look at that image in a variety of different views, we could notice that from just about any view, we had at least a millimeter of space between the adjacent teeth. So, although it wasn't probable to be able to place the implant there, it appeared that it was possible. And so we looked at achieving this with the assistance of a computer-generated pilot guide. Now you can see on the left-hand side that the implant in the area of the tooth number 27 is placed without any damage to the adjacent root surfaces. And on the right side, you can see that, of course, tooth number 21 is clear and free, but we're not sure about the patient's cuspid in this location. What we do see is by changing the angle of the orientation of the radiograph that we're clear from the tooth number 22 that we have not injured it either. So there's no one single view that would represent the full context of the 3D volume of information that we're here to study. So that reveals an inherent revelation, essentially, that there is a three-dimensional space we're studying, and although we could place an implant, we might not be able to execute that without the assistance of a guide. But one must ask the question, are the guides really that accurate? If you were to order a pilot guide and suggest that you're using a 2 millimeter diameter drill, there was a time at which they had sleeves that were only measuring 2 or 2.2. And if you were to use a 2.2 millimeter sleeve and a sleeve length of 4 millimeters, together with flexure of the guide, 3 degrees of angular deflection, your 25 millimeter drill could deviate up to 1.1, 1.25 millimeters, and that could potentially, in that very narrow space, be a problem. Now, if we were to request a different internal diameter of the sleeve, rather than requesting a sleeve of 2.2, if we requested the 2.0 millimeter sleeve, we measured the Dentsply implant's 2 millimeter burr and found that it actually measured at 1.98. And this limited the angular deflection and the deviation of the drill and created an environment where we might be able to more predictably utilize the guide safely. And as I often say, it's important, as Reagan mentioned, to trust but verify. So as we're performing this treatment, verification radiographs were taken midway through the procedure. So what we learned is if we ask for a 2 millimeter, if we indicate that we're using a 2 millimeter drill, we'll get an oversized sleeve for tolerance. But if we tell them we're using a 1.9 millimeter drill, then the pilot guide comes back with a 2 millimeter sleeve. The Dentsply implant's 2 millimeter burr is actually 1.98 and fits perfectly in there. And utilizing that approach, we're able to manage the space and predictably accomplish this task. Now, here are the provisionals in place. In this next image, this is the day of delivery. This patient was so motivated to get the restorations placed, I never recall seeing her again after that. So, managing space limitations is one of the indications for utilizing the surgical guide. Last was describing an interproximal space limitation. This one is going to be a vertical space limitation. As you can see, multiple implants are placed in the mandibular posterior area. As they are placed, you can take advantage of the opportunity to achieve good spacing and accomplish precise clinical results. What I'd like to draw your attention to is the implant in the area of number 30. It has an intended slight distal inclination, and it's resting in its final intended position just above the inferior alveolar nerve near the mental foramen. And that's true on the patient's left side of their mouth as well. And that is exactly as we had intended and planned. Another example of the same, limited vertical height over the mandibular canal. Multiple implants are being planned. We have modified the drill holder, the fixture holder, to be smaller in diameter than the final burr that's utilized, and that enables us to place either supracrestal, equicrestal, or subcrestal that we might accomplish in a narrow ridge to cover the buccal threads of the implant. And once again, this implant was intentionally placed shallow to avoid trauma to the mandibular canal and the mandibular nerve that's resting inside of that. Multiple implants were placed, impressions were created. Eventually, we used splinted restorations with the Dentistry implants 4.0 by 6 millimeter implants. These are very short implants, so there's an adverse crown-to-root ratio. We utilize splinting to augment the load carrying capacity and the resistance to displacement and rotation that might have otherwise been present should those have been non-splinted as opposed to splinted. So we have 2 implants per molar and 1 implant for the premolar and 3 implants for 2 teeth, splinting the units together as you see in these images. So that brings us to the fundamental types of guides that exist. There are bone-supported guides, there are tooth-supported guides, and there are also mucosal-supported guides. The bone-supported guide is the original guide. It has the great deal of accuracy in terms of its fabrication. It doesn't require multiple scans. It has the downside of requiring conventional flap surgery, and it's historically not utilized to create a laboratory restoration unless one is considering immediate loading with a conventional complete denture that's converted. With the tooth-supported guide, that is the most accurate type of guide. It requires an optical scan of the patient's stone cast or an intraoral scan of the patient's dentition. And it utilizes the formerly discussed merged data sets. It allows for minimal invasion, and it can be used to facilitate the creation of a restoration. The mucosal supported guide is one of the most challenging in that it requires often a radiographic scan of the patient's complete denture and or the prosthesis can be created where there is a opaque prosthesis or a radiographic scan of the patient's pre-prosthetic device. And that, if it's radiopaque, can be positioned in the patient's mouth. And if that is scanned properly in the proper position, and it works perfectly well, but the accuracy depends on the prosthesis position when the patient is being scanned. It does allow for minimal invasion, and it can be utilized to create the restoration. I'll discuss a little greater detail about the types and accuracy of guides right now. Ozan and others studying over 110 implants evaluated 3 different types of surgical guides, and he evaluated the angular deviation of the implant as placed versus as it was intended. And they determined that the tooth-supported guides had less angular deviation and less standard deviation than did the bone-supported or the mucosa-supported guides. They noted that the implants were least accurate at the apex and more accurate at the neck. Tooth-supported guides turned out to be the most accurate in this evaluation. Arasan and others looked at the accuracy of 2 types of SLA guide systems. 294 implants were placed and compared to the original Cone-Beam C2. 60 stereolithographic guides were used. Bone guides were compared to mucosa guides, and in this instance they found that the bone-supported guides were less accurate, having higher mean deviations than the mucosa-supported guides. So if we look across the literature, we find that the bone-supported guides are the least accurate, probably due to the extensive flap that is required to position them, and maybe due to the masking. Sometimes the bone is depicted one way in the Cone-Beam C2, and it's slightly different in the mouth with small wisps of calcified tissue that impair the seating of the guide on the bone. Mucosa-supported guides performed better than the bone-supported guides, and tooth-supported guides fared better than either of the other 2. So we might consider what must we have a scan prosthesis. In edentulous arches, we have to have a scan prosthesis. If you scan the patient and you're not wearing a scan prosthesis, there is no way to make any other guide than a bone-supported guide. If you have a well-fitting complete denture, you can consider placing fiduciary marks on that complete denture, 5 or 6 pieces of gutta percha, 5 or 6 tiny acrylic resin beads can be used. We often place tiny little dabs of flowable composite resin. And having a well-adapted and well-fitting complete denture, it can be used with a dual scan technique. Another approach is to use a radiographic, radiopaque scan prosthesis. If the patient has significant tooth loss, historically we were creating a scan prosthesis for these patients, but today we're doing less scan prosthesis and using more merged data sets. So mostly it's the edentulous patient that we're making the scan prosthesis. If there is significant limited bone volume and you have anatomic structures very close, it's critical to be very accurate, and you can merge data easier when a scan prosthesis is in position, and if tooth position is critical as well. These can be indications. In this instance, I'm going to show you a radiopaque duplicate denture. So if you look at the final surgical guide on the right, it's really in the family with the existing denture. A well-adapted, relined, complete denture that has teeth in the proper position can be duplicated in a radiopaque material such as 10% barium sulfate mixed with acrylic resin, or you can use Great Lakes bisacryl, which can or Great Lakes acrylic resin, which can be used for the purpose of creating a radiopaque guide. We often duplicate that original denture. It distorts a little bit, and I would then therefore suggest that following the polymerization of the acrylic resin duplicate, that it be relined intraorally with bisacryl. That's if you're looking for a radiopaque guide. If you want a radiolucent guide, you'll have to have the 6 fiduciary marks, either with lead beads, glass beads, which are available on the Materialize website, Materialize Implant website, or alternatively with a composite flowable resin, as I mentioned previously. The critical issue is to manage the position of the implant, or rather the scan prosthesis. If the scan prosthesis is to be positioned in the patient at the time of the making of the scan, then it's critical that it seats properly and is not displaced. If the patient is referred to a scan center and asked to bite on a bite fork, if they're wearing a complete denture as a scan prosthesis, the bite fork could trip it. So they have to either have an interocclusal registration or bite down on cotton rolls or be trained properly, or if the scanning device is in your own office, you can better manage the position of the scan prosthesis. So the final surgical guide is ultimately a relative of the original scan prosthesis. It's important to make an appropriately seated and fitting scan prosthesis. I mentioned the patient biting down on a bite fork. You can see in this image the posterior aspect of the scan prosthesis is lifted away from the mucosa, and that is a very defective fit. On the right-hand side, you can see the scan prosthesis has been relined with a bisacryl, and it's properly seated and properly fitting. Once again, the side view, you can see in the cross-sectional view that the reline of the bisacryl has allowed for the accurate approximation of the prosthesis to the mucosa. Well, what this results in is a very well-fitting surgical guide, which allows us to achieve the results we intended. In this instance, we're utilizing 30-degree angled implants for an all-in-four concept, avoiding the mental foramen and the mandibular nerve in the posterior region. So, when we look at the indications, managing space limitations, interproximal, buccolingual, vertical, and also angular deviation of the implants. If we're going to try to manage implant spacing or angles, this is another instance where we have a all-on-6 or fixed-on-6, which we like to often refer. And that surgical guide is going to be placed intraorally utilizing an index. And that index is going to be positioned to the opposing arch prior to fixating the surgical guide, which will enable us to get into the next phase, which is the placement of creating the osteotomy and fixating the implants. So as you see in this image here, we have achieved the 30-degree angled implants in the posterior region, avoiding the maxillary sinus grafting. Here we have a well-distributed 6 implants. I have to acknowledge Charlie English for describing the AP spread. That assisted us in minimizing the amount of posterior cantilever, and eventually we went on to create a fixed, simple acrylic resin wrapped cast metal bar with complete denture teeth for this particular patient. So as I mentioned, managing implant position is critical for the indications for ordering a surgical guide. That's interproximal, vertical, buccolingual, also angulation, as I just presented. What are other indications? Inter-implant spacing, possibly, yes, and also orthodontic prediction. So in this next patient, I'm going to illustrate a patient who had a diagnosis of a congenitally missing lateral tooth number 7, and he was also suffering from severe wear, collapsed vertical dimensional occlusion, tipped and drifted teeth, and we were looking at a treatment plan which would incorporate orthodontics. In addition, we also had some missing teeth, and we were planning to place implants, and if we could know in advance where those implants were going to be, we could actually place them, provisionalize them early, and utilize them for anchorage to assist us in achieving the orthodontic movement. So as you see in these images, it describes the before and after proposed orthodontic treatment plan. Just to review that, we could look at the before and after condition of the orthodontic treatment plan. We could superimpose an optical scan of the patient's stone cast over the bone model, and then set virtual teeth in the Implant software to depict the condition of the future proposed teeth. And from that, we can order a surgical guide, and that guide would fit the pre-treatment orthodontic condition. That would enable us to place implants early in the treatment and then continue orthodontic treatment, and then subsequently we would provisionalize those implants to facilitate completion of the orthodontic result. So here what you can see is that we have a patient who is undergoing multiple digital workflows. The first I mentioned was clear aligner orthodontic therapy. How do we accomplish that? Well, physical impressions are scanned and we generate an orthodontic treatment plan. Next, we have a treatment plan for implants, and we would like to order a surgical guide. And we accomplish that by achieving a cone beam CT of the patient. We take a physical impression of the patient's mouth and virtualize that with a three-shape scanner. And then in the Implant software, we merge those data sets, perform a virtual tooth setup, and order a surgical guide. Following the completion of ortho, we'd like to order a CAD/CAM provisional, and we'd also like to do a digital diagnostic wax set. How are we going to do that? Well, at the completion of ortho, we're going to take physical impressions, and we're going to prepare and set virtual teeth. We're going to scan those impressions, set virtual teeth, and order a provisional. Now, historically, we were making physical preparations on the cast, but we learned that the 3Shape software enables us to set virtual teeth, and from those virtual teeth, we can actually perform pseudo preparations, and that the computer imposes a minimum thickness of the provisional over the intended teeth that are going to be prepared, and then we can export that STL file for milling of an acrylic resin polymethyl methacrylate provisional restoration. Once the patient is provisionalized and final impressions are made, we like to use Atlantic's patient-specific CAD/CAM abutments. Well, the way we accomplish that is from the master cast, we scan and perform the digital design. If we have multiple implants, Atlantis will request that we submit a wax up that seats onto the master cast. So we made the physical impressions, scanned that, performed the digital design, and exported an STL file for the creation of a CAD/CAM wax up, which seated onto the master cast. From that, we received the custom abutments that you see here in teeth positions numbers 4, 6, 13, and 15. Those are Atlantis abutments. The rest are natural teeth. The final impressions, we would like to eventually go on to making zirconia cast full occlusal and proximal restorations. Rather than cast, I mean anatomical cutback for the layering of felspathic porcelain. The way we do that is on the master cast, we scan in those newer Atlantis abutments in place, we perform the digital design, we then do the anatomical cutback radiographically, not physically. Once the design is intact, we export the digital STL file, its output, and sent to a milling center, or in the milling arena, that STL file is indexed into the block, nested, milled. Following milling, there is a coloring or infiltration and sintering at 2950 degrees. Eventually, porcelain is stacked, and the restorations are baked and finished. This is the image of the 3Shape software with the maxillary and mandibular restorations at the full contour prior to cutback. You can see here in this view the transparency will reveal that there is physical dies. These are laboratory models that have been trimmed, the high-resolution scans mathematically on top of those dies. The computer superimposes a space for a die, identifying the margins in green, the die space in kind of a yellow, and then minimum thickness is imposed for the restoration so that anywhere where we design a restoration that's too thin, the computer will superimpose the required minimum thickness for the safety and strength in the restoration. Those are two images. One is the full contour preliminary provisional, and the other is the design of the STL file for output for zirconia on the right with the facial anatomic cutback. This is some of our first designs where we're actually using interproximal as well as lingual and occlusal full contour zirconia, with the exception of the facial buccal cutback. By having that facial cutback, we have the opportunity to layer conventional feldspathic porcelain that's matched to the underlying zirconia ceramic, and in that we can impose the artistry that a master ceramist might like to achieve utilizing whatever medium possible. In this instance, we know that the ceramists do a great job with porcelain fused to metal, but we're using this new porcelain fused to zirconia with full contour occlusal zirconia. So the patient received in the mandibular arch third molar extractions and the restoration of their vertical dimensional occlusion with these restorations. Here's the radiographic result with multiple Dentsply implants in the maxillary arch, CAD-CAM abutments with the Atlantis abutment, and zirconia restorations. So that leads us to how these restorations are created.